Welcome, sir.
In the previous sessions, we had discussed about the ischemic stroke and the hemorrhagic stroke, intracerebral hemorrhage. The next part is about the subarachnoid hemorrhage or maybe the extracerebral hemorrhages, which can produce the similar symptoms as that of the stroke. And the most common cause for the subarachnoid hemorrhage is a trauma. And next to that, after the trauma, in the traumatic conditions, where there could be any reason. Then the third variety is what we call as the spontaneous hemorrhage. Spontaneous hemorrhage is where without any structural pathology or not even without trauma, a hemorrhage can occur in the subarachnoid space due to some either hypertensive complications. But from the clinical point of view, traumatic hemorrhage is one. Now that about the traumatic hemorrhage and their issues, we will discuss when we discuss about the head injury in the next sessions, coming sessions. So I leave that part. We will limit only to the other non-traumatic hemorrhage, and among the non-traumatic hemorrhages, more than 64% of them are the aneurysmal hemorrhages. The aneurysm is the dilatations of the blood vessels which can occur anywhere, and the causes for the dilatation are, it could be either a abnormality of the wall of the vessels, or it could be the hypertension, or it could be due to the mucosal abnormality of the tunica intima of the vessels. But when it is dilated, it can produce two consequences. As it is dilated without even getting rupture, if the size is bigger, it can produce a compression upon the nerve tissues nearby. Particularly in the intracranial area, the compression effect can be more because the skull is not expandable. An aneurysm elsewhere also can produce a compression sign, but the compression sign compression sign could be of lesser significance in the other conditions, whereas compression effect can be more in the intracranial area because the skull cannot be expanded. Now, but more important than that is aneurysm may get ruptured. Now, whether the possibility of the rupture of aneurysm is another critical question. See, we may have many patients who are diagnosed with aneurysms, microaneurysms in the brain, and they may come for the second opinion, like whether surgical treatment is required or not. Now, that the opinion is quite difficult to say. There is a general prediction of the outcome would be, that's one law of Laplace. Law of Laplace states that the tension within the aneurysm or the possibility of the aneurysm can be predicted by the pressure gradient across the wall of the aneurysm. So if the intravascular pressure is more, and outside the aneurysm the pressure is lesser. So suppose an aneurysm occurs in the within the brain tissue, the brain tissue would be producing some outside compression and chances of the rupture would be lesser. Whereas if the aneurysm occurs in the extra scapular, extra skull area, outside the skull area, or at the outside the brain area in the subarachnoid space, the pressure outside is lesser. So that gradient, the difference between the pressure within the vessel and outside the vessel becomes more, and hence chances of rupture there are more. So that's what we call as a law of Laplace. Law of Laplace is a law which predicts about the higher possibility of a rupture of aneurysm if the pressure within and outside their difference is more, then the chances of the rupture of the aneurysm is more, and size of the aneurysm also will be bigger. A aneurysm present in a compact tissue like within the brain, the chances of rupture are lesser, though it's not that it won't rupture. But in general, based upon the statistics, the other way, a aneurysm with a diameter of 5 mm has a lesser chance of the rupture. It's around 2% risk of the rupture. Whereas a diameter is more than 6 to 10 mm, then almost 40% of the patients will be diagnosed of the aneurysm only after they have rupture. So already they have rupture, and the risks of rupture there are quite high. So prediction of the risk is quite difficult in such conditions. But still, what we generally do is, see, when a patient comes to me, what I do is, if the patient is hypertensive, if the patient has a aneurysm outside the pyometer, and if the age is around maybe around more than 50, chances of the rupture are more in such conditions, which may require intervention. Otherwise, if the size is less than 5 mm and if it is within the compact brain tissue, chances of rupture are lesser. So that's how it has to be predicted. So once a aneurysm gets ruptured, the blood gets accumulated in the subarachnoid space. It may even expand within, and the arachnoid membrane will be just pushed within into the tissues, and the brain tissue may be compressed. The blood will be mixed with the CSF and produces a global sign, can produce a global sign. Or occasionally, even the arachnoid membrane may get ruptured, and the blood may get into contact with the grey matter or the white matter of the brain tissue, which can produce the same symptoms as that of intracranial hemorrhages. Clinical presentation of a hemorrhage, that subcutaneous subarachnoid hemorrhages, are around 48%. Almost every patient would have a typically headache as the initial symptom, and characteristically it's a sudden onset and very severe headache. That's the classical feature, which may not respond to the usual analgesic treatment. A sudden onset of the headache along with the symptoms like a dizziness, pain in the eyes, or vision abnormalities, or complete loss of vision. These are the most common clinical symptoms of the subarachnoid hemorrhage. Particularly if the headache is presented as a sudden onset of the headache and it accompanies nausea and vomiting, and there are signs of meningeal irritation like neck rigidity, photophobia or visual changes, and if there are any neurological deficits, focal neurological deficits like loss of movement or abnormal movements or seizures which may occur, or sudden loss of consciousness as such, then it is almost confirmatory of a subarachnoid hemorrhage. The other signs which could be presented are in the patients of subarachnoid hemorrhages, which can make the diagnosis, would be sensory or motor disturbances, loss of sensation or impaired sensation somewhere, or movement, abnormalities of movement. Seizures are seen in around 4%. Ptosis, that's eye closed, not able to close, that may be present in 3%. Bruise or murmur like sounds heard over the vessels, over the neck vessel, is also may be seen in 3%. Abnormality of the speech is 2% as such. Majority of the patients may have mild to moderate elevation of the BP. Blood pressure will be slightly raised in majority of the patients. Fever is another common clinical symptom which may follow the subarachnoid hemorrhage. Tachycardia, papilledema seen under the fundoscope, or retinal hemorrhage which also could be seen under the fundoscope, are neurological deformities, abnormalities, either generalized if it is a bleeding into the CSF, or focal, localized if there is a bleeding into the brain tissue. That could be the clinical signs. Now, CT image or MRI image would be confirming the pathology, and the evidences could be in an aneurysmal hemorrhage. You may see the spot of the aneurysm, and the blood may even leak into the ventricles as well as the CSF, so a generalized edema of the brain may be seen. Whereas in a spontaneous hemorrhage, which may occur, most of the times it will be in the subarachnoid space, and it may even penetrate through the arachnoid membrane and get into the brain tissue as such. A small variants, common variants which could occur could be subdural hemorrhage where it may be below the dura mater, not the subarachnoid, and in that condition too there could be an expanding lesion. The blood clot may be expanding from the periphery. A traumatic hemorrhages, subarachnoid hemorrhages, also can be expanding. The characteristic feature in a case of traumatic hemorrhage, subarachnoid hemorrhage, is the presence of lucid interval. Lucid interval in the sense a patient may have a head injury, and at the moment the patient may have a concussion, and the patient may have a temporary loss of consciousness, but the patient again recovers. Then again, after a certain period of time, there could be gradual and progressive deterioration, and neurological symptoms could occur like headache, vomiting, as well as impaired movements could occur, and that's very characteristic of a traumatic subarachnoid hemorrhage or subdural hemorrhages in trauma conditions, that lucid interval, that a time gap between the onset of the trauma and then the onset of the clinical symptoms. That's the typical presentation. Once the patient is of a subarachnoid hemorrhage, to plan the management, that you need to grade it, and the grading is done by the usual standard WFNS grading system. That's World Federation of Neurological Surgeons grading system. If the Glasgow Coma scale of 15 and there are no motor deficit as such, then it's called as grade 1, which can be managed more of the times medically, and you have sufficient time to manage the patient, if plan for the surgery if necessary. Grade 2 is when the Glasgow Coma scale is 13 to 14, slightly lesser. When I say Glasgow Coma scale 15, there are no evidences of any loss, normal. 13 to 14, and there is motor deficit is not present, that's called as grade 2. Grade 3 is there is a motor deficit present, but the Glasgow Coma scale is in between 13 and 14. Now in these two conditions there is no need of life support technique, but the patient has to be managed somewhat rapidly because there is a chances of progression. So early intervention is required in grade 2 and grade 3. Grade 4 and grade 5, where the coma scale is in between 7 to 12 or 3 to 6, and motor deficit either present or absent. Because the coma scale is lesser, such patients require an immediate life support treatment like intubation and hyperventilation may be required. So that's how it has to be decided. Treatment, the primary is about life support, and for the life support, intubation and hyperventilation, and the criteria is either if intracranial pressure is increased or if the patient is in a grade 3 or grade 4 conditions. Above grade 3 conditions, it requires intubation as such. The other part of the management is antihypertensives. Antihypertensives, earlier it was believed that every patient of subarachnoid hemorrhage would be prescribed a antihypertensive, but now the current guideline, the latest guideline is antihypertensives are prescribed only when the mean arterial pressure is more than 130 millimeters of mercury, and that too the drug of choice should be beta blockers or calcium channel blockers. Other antihypertensives may increase the intracranial pressure, and that's not prescribed as such. The osmotic agents, as in any other stroke conditions like mannitol, can decrease the intracranial pressure, reduce within 50 to 30 minutes. So 50% of the intracranial pressure can be reduced within 30 minutes as such. So hence they are usually prescribed as a time-bound measure before planning for surgery, or even if you are planning for surgery to facilitate the surgical procedure to reduce the brain damage. The osmotic diuretics are essentially prescribed in case of subarachnoid hemorrhage. Now see, osmotic hemorrhage, these agents like mannitol, prescribed in a stroke condition, that discretion is quite important. In case of intracranial hemorrhages, they are not indicated. In case of ischemic conditions, selectively they are indicated. In case of subarachnoid hemorrhage, they are the drug of choice. They are needed. So that selection and prescription of that should be done carefully after correctly assessing the condition, where though the clinical presentation may have lot of similarities. Loop diuretics like furosemide, that's Lasix like conditions, also can help in reducing the intracranial pressure and making the patient recover. Glucocorticoids, whether they are indicated or not, of course, the general prescription everywhere glucocorticoids are prescribed in patients of subarachnoid hemorrhage to facilitate the recovery, to reduce the damage, but theoretically there is still a question mark. As in case of the stroke condition, here also in the general ischemic stroke also, glucocorticoids, whether they are really beneficial or not, there are a lot of difference of opinion. Similarly with the subarachnoid hemorrhage also, glucocorticoids, there is a difference of opinion, but still popularly glucocorticoids are prescribed, and in my experience also I would prefer to have glucocorticoids in such conditions. Then once the hemorrhages, these aneurysms are diagnosed, ultimate treatment would be surgical treatment. Surgical treatment could be either the ruptured aneurysm has to be clipped, or it could be endovascular obtrusion, that the aneurysm should be closed as such. Major complications which can result in serious fatal results could be hydrocephalus may occur, that's the intracranial pressure may increase, there could be rebleeding. Temporarily, it may look like the patient may have improved, but there could be again a bleeding asset. Later on, there could be cerebral ischemia or vasospasm could occur in the patient of hemorrhage, even if the hemorrhage is stopped. Even after the surgical intervention, this complication can occur occasionally, and it also can result in intracerebral hemorrhage or intraventricular hemorrhages, which I just referred to earlier. It can also result in the cardiac pathologies, subdural hematoma or intracranial subarachnoid hemorrhage, hematoma can result in cardiac complications like left ventricular systolic dysfunction and myocardial infarction. These are very common. A subarachnoid hemorrhage can result in a subdural hematoma later on, or it also can increase in the intracranial pressure and produce a global compression, or seizures also could be the persistent complications. That's about the subarachnoid hemorrhage. The next part which we discuss would be about vertebrobasilar stroke. Now, vertebrobasilar stroke is as good as any other stroke. It's actually an ischemic or the hemorrhagic stroke, particularly ischemic stroke. But we consider this as a separate entity because of the unique clinical presentation and the importance of the vertebrobasilar artery. Now, vertebrobasilar artery system is one of the important arterial system which maintains the blood supply to the brain. The vertebral artery passes through the cervical vertebrae, enters into the skull through the foramen rotundum, and then both of them they would be merged together. Vertebral arteries merge together and form the basilar artery. So, basilar artery is formed by these vertebral arteries, two of them they would be merged in. And then after the formation of basilar artery, there will be the pontine arteries which provide blood supply to the pons area and the medulla oblongata area, as well as cerebellum. Then posterior cerebellar artery, that's the posterior cerebellar artery which gives the blood supply to the cerebellar area. Then it forms the circle of Willis. So, and circle of Willis, it gives out the branches to whole of the brain. So, importance of the vertebrobasilar artery is that it involves or it mainly supplies the brain blood supply to the pons, cerebellum, and major portions of the extrapyramidal or extracortical areas as such. So, description of the vertebrobasilar arteries. Vertebral arteries arise from the subclavian arteries, and as they goes up into the neck, they pass to this foramen and enters into the this transverse foramen of cervical 2nd to 8 as such, and they enter into the skull through the foramen rotundum. And the vertebral artery gives up the same issue which I have just mentioned about, gives up the branches to the area. Medulla particularly is perfused by the posterior cerebellar artery and the smaller branches of the vertebral arteries. Pons also is perfused by the same. So, that's about the importance of vertebrobasilar artery. The most common vascular condition affecting the vertebrobasilar system is atherosclerosis. Patients with atherosclerosis, particularly old age patients, hypertensive patients, they tend to develop vertebrobasilar stroke-like symptoms or obstruction to the vertebrobasilar conditions, where the arteries become narrowed and the plaques are formed. The small vessel disorders also are different from the atherosclerosis because certain of the patients may have the small vessel disorders where minute capillaries may become blocked, and they are usually associated with the hypertension and lipohyalosis. That's the degenerative changes in the vessels. So, the typical presentation in this would be, in case of atherosclerotic plaques, the onset of the symptom could be somewhat sudden, whereas in the small vessel disorders, the symptoms could be gradually progressive. The characteristic clinical symptoms produced due to vertebrobasilar stroke would be when the cranial nerves are involved in the vertebrobasilar system, the lesion would be ipsilateral. That's very characteristic. Ipsilateral in the sense same side as that of the involvement of the nerve tissue. See, if it is a central pathology, if a pathology occurs within the brain tissue above the nuclei, then the symptom would be contralateral on the opposite side of the lesion. Whereas if there is a involvement of a cranial nerve on the ipsilateral area, that's suggestive of a lower lesion or a lesion which is at the below the circle of Willis area, and It's usually involvement of the vertebral cellular signs. Then other characteristic clinical symptoms which are presented would be cerebellar signs, dysmetria, ataxia, which we have already discussed. Cerebellar signs could be presented, and another is the patient may have involvement of the sensory pathways. Sensory pathways like sensations could be affected in majority of these patients. It could be of different sort of the sensory pathologies, like either it could be only the touch sensation which is lost, it could be pressure sensation or vibration sensation, or maybe all the sensations. So that's also another of the typical presentation. Dysarthria or dysphagia also is typical presented in case of vertebrobasilar symptoms. And another common clinical symptoms of vertebrobasilar symptoms are vertigo like nausea, vomiting, or nystagmus. Typical vestibular system involvement symptoms could occur, or Horner syndrome, pupillary abnormalities, one pupil being constricted and the other being dilated, something which we have discussed in the initial classes, also can occur in case of vertebrobasilar symptom. Then there could be impairment of visual loss or visual space effects, like, or there could be rarely cortical defects like aphasia or cognitive impairments. They are generally absent. They are not correct general seen. See, that's the basic difference between a cerebral stroke and vertebrobasilar stroke. In the cerebral stroke, the abnormalities of the cortical functions, aphasia, impairment of the cognitive functions are common. Whereas in vertebrobasilar symptoms, it's mainly extrapyramidal symptoms or the symptoms in all of the pyramidal conditions. Causes, of course, there is increasing age is one of the common causes. There would be usually a family history of such conditions. Patients may have that history of vertebrobasilar symptoms, like extrapyramidal symptoms earlier. Certain races are more common, of course, the black races like Indians and Africans, they have higher chances. History of stroke, if a patient had a history of stroke earlier, chances of vertebrobasilar involvement also are more common. Hypertension, coronary disease also aggravates the same. Diabetes mellitus is another of the conditions. Cigarette smoking, cardiac pathologies, obesity, physical inactivity, drug or alcohol abuse also are considered to be etiological factors. Now the same symptoms which I have already mentioned, it is the very common presentation of the clinical symptom will be vertigo, nausea, headache, abnormalities of the level of consciousness, moderately not unconscious, abnormal oculomotor signs like nystagmus or this position of the eyes being altered, diplopia, etc. Then cranial nerve weakness, the same which I have discussed, like sensory loss, ataxia, contralateral motor weakness. Motor weakness if it occurs on the opposite side as such. Pain and temperature loss, sensation of pain or temperature loss, incontinence, visual field defects, presence of central pain. Some of the patients may present with the severe pain as the onset. Then there could be some sweating in the face or extremities. Now, based upon these set of clinical symptoms, they are categorized into huge number of syndromes. The vertebrobasilar conditions, they are categorized into huge number of syndromes. That number of syndromes present in the neurological textbooks are enormous. I would not go into all that. The most important, most commonly clinical symptoms would be midbrain syndromes, where the cranial nerve third lesion with vertical gaze palsy. Patient may have visual abnormality. These are very common. Pontine syndromes, where the patient may have horizontal gaze palsy and the seventh nerve palsy symptoms. Medullary syndromes, where the patient may have a facial pain, usually on the same side, facial pain, temperature loss, that visual pupillary abnormalities, Horner syndrome, ataxia, or loss of pain and temperature sensation. These are next common. Posterior cerebral artery, where there could be hemianopia with the macular sparing, where the macula may be left over. Then, if just for the sake of your interest, I will not go into any of these details. Based upon that variations of the clinical symptoms, the syndromes are of different categories. If you read a neurologic textbook, you will come across these different syndromes. I will not go into the detail of these, and they are either lateral medullary or Wallenberg syndrome, medial medullary or Dejerine syndrome, or cerebellar infarctions, locked-in syndromes, top of the basilar syndrome, internuclear ophthalmoplegia, 1.5A syndrome, ventral pontine or Miller-Gubler syndrome, upper dorsal pontine or Raymond-Cheston syndrome. Of course, there was a typing error. These are repeated. lower dorsal pontine syndrome, ventral midbrain syndrome, dorsal midbrain syndrome, posterior cerebral artery occlusion. Now these syndromes do not make any importance from the clinical point of view. It's only from the academic point of view are these differences are made out. It's only about slight variation in the clinical symptoms it make out that. So with that I will not go further into the detail. Now there could be an acute vertebrobasilar artery stroke also can occur, where the patient may have unstable or fluctuating neurological symptoms with the decreased level of consciousness. Comparatively, acute vertebrobasilar artery stroke are less common, whereas the chronic one is more common. And acute conditions may present with the severe shock-like conditions, where the patient may have a loss of reduction of blood pressure, as well as cardiac or respiratory pathologies latent to occur due to the involvement of the pons and the respiratory centers. And the outcome of that would be poor. But luckily, incidence is less common in case acute vertebrobasilar conditions. Complications which can occur after the vertebrobasilar stroke, mainly the respiratory involvement, because the respiratory centers are in the lower part of the brain, they tend to get involved if there is an expanding, and hence aspiration pneumonia or other pulmonary embolism, myocardial infarctions, which can result in other fatal complications can occur. Patients of vertebrobasilar stroke also have a high risk of deep vein thrombosis, which can be presented as such. Now, that's about vertebrobasilar symptoms, and of course, as far as the management is concerned, it follows the same principle of management as that of other strokes. There is no other specific management for the vertebrobasilar symptom. From Ayurvedic point of view, I would prefer Smritsagarasa and Ekagavira in such conditions than the other usual management, but other part of the management would be the same. Now, that's in general about the basic issues related to the stroke pathology. Now, the last part of the stroke is about the recovery after the stroke. See, in the stroke management, there are two aspects of the management. One is about the acute management. Acute management part we have already discussed, like where either it could be antihypertensive drugs or anticoagulants or maybe platelet aggregation inhibitors or the surgical treatment. These are the different options. Once the patient has developed the stroke, the deficits they tend to remain for a long time, and the recovery is a slow process. And that recovery from this stroke is what we call as the neurological recovery. Functions of the nerves may be improved, but whether the real nerves get regenerated or not is again controversial issue. I will come to that part. Like regeneration of the nerves is one issue. Now, the recovery stages usually they are categorized into 6 or in some texts 7 stages. That's initially at the time of the stroke, the patient will have a flaccid paralysis. Then gradually there will be movements which may occur in a typical synergy pattern, like one by one, step by step. There could be an increase in the movement, and there could be a gradual increase in the spasticity. Then in the stage 3 is where the patient may have a voluntary movement. Patient is able to have a voluntary movements which can have some coordination. The patient can have a purposeful movement, and across the joints the spasticity may increase. And if the patient is recovering well, in the 4th stage there could be voluntary movements outside the synergy patterns, like where the patient may do the movements with a purpose, and some specific skilled jobs also may be possible. Spasticity may be reduced. And stage 5th is a perfect control over the individual isolated movements, where the skilled jobs can be done easily. And stage 6 is return to near normal or motor control. This, whether the patient would recover or not, that depends upon the type of the stroke as well as the amount of the pathology. From Ayurvedic management point of view, this stage wise our approach has to be somewhat very classical. In the flaccid paralysis stage, I would consider this as Kapha Vata, and I would prefer Agni Chikitsa and Matragasti. Whereas the most common popular treatment like the Pindasveda is not to be done at the flaccid stage. Instead, only after the patient has gone into the stage 2, where I would consider this as Kevala Vata Janya Vyadhi, and there the Pindasveda or Brahmana Bastis are indicated. Physiotherapy is another part of the usual protocols in the which facilitate the stroke recovery, and they are meaningful or they would be useful when the patient has some voluntary synergy. Patient is able to have a voluntary movement, then to facilitate the movement, physiotherapy may be indicated. If the patient doesn't reach to the stage 4, and the majority of the patients, they may come to the stage 3, and then there could be a stagnation. They may not reach to the stage 4. In such conditions, Virechana may be helpful. If the patient is progressing well, the Virechana may not be necessary. This is what I have observed and which I generally plan. Now, the other theory part, like how the neurological functions would recover, whether there will be regeneration or not. There are different theories of regeneration or improvement of the stroke. The one theory says that there would be a collateral sprouting of the nerve tissue, axonal regeneration may occur, and that axonal regeneration is if once the nerves are damaged, gradually the axon's new branches are regenerating, sprouts are formed, and the nerve may become normal, provided it's only the axons which are degenerated. But if the neurons, the neuron portion, the cellular portion is degenerated or damaged, there may not be a recovery. That's one of the general rule. And that axonal regeneration is facilitated by improving the status of the patient, like a general condition. If it is maintained, it's a natural process occurs. Then another theory is one where the patient may have a functional improvement due to the newer circuits form. See, I think the simpler way is we have around 300 nerves in reserve for one of the nerves which is functioning. The reserve of nerve tissue is around 300. In the sense, in the lifetime, you will be using only 1 in 300 nerves for all the normal functions. 299 nerves are kept as reserve. So if one set of the nerves are damaged, then the functions of the body, which are form of a circuits which are mentioned, these circuits may be formed, newer circuits and newer synaptic pathways may be formed in the other areas, where the reserve nerve areas, and hence the function may get regained. There may not be an increase in the nerve tissues may not regenerate, but the functions will be formed by the newer circuits formed. And this newer circuit formation process can be facilitated by training. Now, there are extensive studies done of how the nerves would be regenerating and these functions would be formed. The most established theory is about the neuroimaging during recovery, where the new circuits being formed are proved. See, the neuroimaging done after 3 days of the stroke, 5 days of the stroke, 10 days of the stroke, in a patient who is having a better recovery as such. In a patient where the patient may remain in impaired conditions, where the recovery is lower, chances of recovery is lower, or if the patient is in extremely severe condition where the recovery is lesser, still there is some amount of the changes in the circuit system which is proved. And this is one of the important recent research studies published and published in 2020, and it has carried a lot of significance as such. So those who are interested, they may read this article, which is quite rather elaborative over the stroke concepts and the stroke recovery as such. But one of the very popular theories about the stroke recovery and important principles of the stroke recovery is at the onset, usually the upper extremities are more involved in the recovery than the lower extremities. This is the usual trend. And eventually, after one step, the involvement of the upper or recovery from the upper extremity, then the lower extremity would be involved. And if this upper extremity weakness is severe at the onset, and the timing of the return of movement in the hand are the important predictors of eventual motor recovery in the upper extremities. So if the upper extremities, hands movements have not recovered within 2 to 3 weeks of the stroke, chances of the recovery is lesser. So the rule is if no initial motion is noticed during the first 3 weeks as such, or if motion in one segment is not followed within a week by the appearance of motion in the second segment. If there is a slight recovery in one segment, like the patient is able to move the arm up and down, but the finger movements have not recovered after 3 weeks of the initial one, then the prognosis of full motion is not favorable. There should be step-by-step, synergistic step-by-step progressive improvement. Then we can predict that the patient can improve well. Now these prediction factors are quite important when we deal with the patients of strokes to predict the outcome, because most of the patients would expect you, the physician, to predict like what would be the outcome. and the prediction will be based upon the first 3 weeks progress as such. Then most recovery stroke patients occur in the first 3 months. Then further after 6 months, the chances are lesser, recovery may be lesser, but still recovery may continue over years together. So even if there is a significant delay, there is some purpose in treating the patients of stroke. The WHO guidelines of treatment of after stroke. Now, management of stroke is one part. After stroke management, the WHO guidelines gives three important issues: early mobilization, then therapeutic positioning is medicines where the patient may have to be kept in an upright position, and the hypoxia inducing position should be avoided. That's bending forwards position should be avoided. That helps in recovery. Erect posture is better. So make the patient mobilize as early as possible and keep the patient in erect. You might have seen during the rounds, like every time when I go for the rounds, I would ask the patient's party to keep the patients erect. The purpose is the same, like that is the best position in which the oxygenation would be improved and the chances of hypoxia would be lesser. Then as far as the activities are concerned, there are two aspects, there are two views, like one is a general physiotherapy given and the other is the activity activity of daily living. Now ADL, or activity of daily living, is one of the recent concepts which have developed, and WHO guidelines has stressed upon this part. So instead of going for a general physiotherapy where individual muscles are stimulated or some nerves are stimulated, there are various techniques. I will come to that part. Instead of that, making the patient or facilitating the patient do some activities which he is doing otherwise, his daily living activities. Daily living activities again could be of anything depending upon the occupation of the patient, and which may require some specific training, and that's much better than simply a general physiotherapeutic approach. A general physiotherapeutic approach could be of different sorts. Now you might have gone to our physiotherapy department and have seen that the most benefits of physiotherapy intervention is the muscle stiffness and spasticity may improve, problems with the movement and balance can improve, pain in the joints may improve. But as far as the specific functions which are necessary for the lifestyle, they need to be given in a different manner. So in a patient of stroke recovery, I would be prescribing physiotherapy only in those patients who have extreme spasticity or stiffness. Otherwise, physiotherapy is of relatively lesser use. Instead, a better approach would be make the patient do the normal activities, like ask the patient to walk more, ask the patient to do some activities which are required, like eating by himself or brushing the tooth and so on. Certain of the specific recommendations, again WHO recommendation would be like which are the specific physiological or maybe physiotherapeutic interventions which are recommended instead of a general therapy. The WHO recommendation would be ankle foot orthosis, like to have facilitation of the foot movement, individual interventions like ask the patient to brush the tooth by himself, wash the mouth by himself and so on. Gait oriented, ask the patient to walk and one, or a repetitive task training, do the same activities repeatedly, and muscle strength training to improve muscle strength, like catching a ball or catching a harder object and so on. Rehabilitation, making the patient to go for the job or go for the normal environment as early as possible. These are the most recommended suggestions than the general treatment like routine treadmill training or EMG biofeedback, like what the muscular stimulation does occur, or balance platform, like which are usually part of that physiotherapy unit training. They are not recommended as the general measures. This important issue. So whatever there is a general perception, like when I deal with the patients of stroke, I refer the patients to the physiotherapy department much lesser in number, whereas the general course would be more. So there is a sort of a perception, but that perception is based upon the solid academic background, and there is a strong recommendation that that kind of a general treatment would be less useful. Only when the patient who is capable of independent in walking, the treadmill training would be used. Functional electrical stimulation may be for specific conditions like a drop foot or foot drop conditions, or if the patient may are walking aids, something like a supports or walkers, they could be the other uses. Lot of new research is coming up now to help the patient from recovery of the stroke, and this is about uh, different levels of that studies. Many of them they are in the experimental study, preclinical development like monoclonal antibodies, and how it is progressing. Still ready for clinical application, very few of them there, and there is always a better scope for Ayurvedic protocol, Ayurvedic treatment of either Agni Chikitsa or Pinda Sweda or maybe the Virechana, any of that. The complications that can occur during the rehabilitation, there are incidence of complications will be more. Overall complications they occur at a very high rate of 60 to 90%, and the most common complications are falls or injuries, incontinence, delirium, depression, dysphagia, pulmonary embolism, or psychosocial problems, drug effects and interactions which could occur. The common incidents which may have occurred would be that respiratory abnormalities 20 to 60%, dysphagia 35 to 70%, aspiration pneumonia 10 to 20%, urinary tract infection 10 to 30%, pain 15 to 40%, depression 15 to 25%, recurrent stroke 5 to 30%, epileptic seizures 10%, myocardial infarction 2 to 6%, congestive cardiac failure 3 to 10%, cardiac arrest 2 to 8%, gastrointestinal hemorrhage 3 to 5%, deep vein thrombosis 2 to 4%, decubitus ulcers 1 to 4%. This is about the global statistics. Of course, when we deal with our Ayurvedic treatment, and then if you have to compare like whether your treatment has really benefited the patient or not, you need these statistics. If your statistics is better than these statistics, if the complications produced in your series of patients is lesser than that, then you can claim that your treatment has been more beneficial, and do not expect the patient to recover completely. Now, whenever the patient has a functional deficit, there is another responsibility would be to give a certificate. When what would be the now, because with the issue of insurance claims and so on, deficits and deficit grading is one of the issues which again can be quite serious occasionally. Now, WHO classification of functioning and disability health, there is one important document. I think it's, I will not go into each of the detail but those who are in the practice, they have to have some idea when you give a certificate to the patient about the disability, because the issue of compensations and so on, they will come up. Many times it may even take you to the court also. So in such conditions, whenever you give a certificate, you need to follow this, and I would recommend you to go into this document, WHO document, International Classification of Functioning and Disability and Health, ICF document, because dealing with that would be quite difficult in our limited time. That document is around 200 pages, 200 plus pages document which is available. So I would suggest you to go through that. But very basic issue is impairments of problems of body structure. They are categorized into 3 categories. The body structural impairment like paralysis or blindness. Then activity limitations like patient is not able to walk or eat or so on. So you may specify, classify whenever a patient deficit, functional deficit has to be recorded. You have to mention these in the 3 categories. Then partial scale restrictions like patients may have discrimination or difficulty in moving, transportation, etc. The common impairment after the stroke which are to be considered are aphasia, apraxia, arm or hand weakness, cognitive impairment, dysarthria, dysphagia, facial weakness, perceptual impairments, sensory loss, upper limb impairment, visual problems. These are the issues which we have to consider. Common activity limitations which I would consider are bathing, communication, dressing and grooming, eating and drinking, participation restriction, psychological, sexual functions, toileting, transferring, urinary or fecal incontinence, walking and mobility. Now, my purpose of referring to these issues in brief is, suppose you have to certify a deficit in patient, you have to mention which of these functions are not possible in that patient, and then you have to mention, of course, the other psychological complications which can occur in such patients are other issues which have to be considered as a part of the deficit classification would be anxiety, confusion, depression, emotionalism, falls, infections, malnutrition, pain, pressure sores, recurrent strokes, shoulder pain or shoulder subluxation. These also have to be mentioned. That's in brief about that part. But I am not going to that detail later. Detail much as such, because otherwise it will be too elaborate. Then the last part otherwise would be prevention of stroke, whether the stroke is preventable or not. How to prevent the stroke? This is one of the important issues. There are lots of literature by which you can, there are prediction of maybe that prevention is suggested. But the latest and the most important guidelines, I have picked up a few of those important guidelines, and that guidelines, many of these sentences I have copied as such to highlight the issues. One is the guidelines strongly recommend that BP below 140 90 by 90 millimeter of mercury to prevent a first stroke. So now about the hypertension and blood pressure control, now the criteria from American Heart Association is changing, and maybe in some other situation we can discuss about that issue also. The 120 by 60 is considered as a normal, but the major guideline says it's not necessary, that low pressure is not necessary. Ideal is 140 by 90 millimeters of mercury, which has to be maintained to prevent the stroke. First stroke can be prevented effectively, and in the patients who with the hypertension or diabetes or renal disease, the goal should be slightly lower at 130 to 80, because the other factors may increase the chances of the stroke. Statin therapy is recommended for primary prevention of the ischemic stroke if other risks also are present, and increased risk of intracerebral hemorrhage with the statin use are identified. So statin being prescribed in every patient, this is another of the major troubles which we see in the clinical practice. Almost every patient, I think I have referred to that issue earlier also. Statin prescription is a common fashion now, and there is a opinion as such, and this has to be kept in mind. Stopping smoking, low fat diet, and Mediterranean diet, that's the low fat diet, weight loss, regular exercise should be encouraged as strongly as a pharmacological treatment. More than the drugs, these are important. Reducing the sodium intake and increasing consumption of food in high potassium to reduce the BP may also help in primary prevention. Low physical activity increases the risk by 3 times. This is important, very important. If you do not do regular exercises, if you prefer vehicles for moving within the campus, you have a high risk. The risk of stroke developing could be 3 times more than the others. Now, the mortality rate of ischemic stroke has been declining globally. Now, the newer development, the mortality rate has been reduced due to more active and more methodical involvement of this. And initially in 1990s, the percentage mortality rate was 71.3, whereas now it has reduced to 57.3 in 2013. 2023 data is not available, but it shows still a reducing trend. It's around 50%. Then the 30-day mortality rate of ischemic stroke is estimated to be 24.7% and 15% in high-income countries like America, 24.7% in eastern countries. Now, these data are important when we consider the clinical output of your patient series. When you have treated a patient, there could be some mortality figures. So naturally, patients, when there is a mortality figure, you may feel like whether your treatment is proper or not. Now, if your treatment outcome is within this range of mortality figures, then you can say that you are in the proper rate sign as such. Survival rate after ischemic stroke by year is 1 year 40.3%, 2 years 51.9%, 5 years 72.8%. This is one. And the median survival after an ischemic stroke is about 1.8 years. These data are important to highlight utility of your treatment. Similarly, with the hemorrhagic stroke, 30-day mortality rate is around 40 to 50%. 5-year survival rate is 26.7%. Intraventricular involvement with associated hydrocephalus. If the patient has a hemorrhage with the hydrocephalus and intraventricular one, then 43% at 30 days mortality will be comparatively high. With this, we will conclude about today's session and stroke. In the next session, we will discuss about headache, another very interesting and important clinical condition, and neurological relations. With this, we will conclude. If there are questions, like there are some questions. Which Panchakarma you suggest in ischemic and hemorrhagic stroke? I think I have already answered that question. In the patients of stroke, in the initial stages, I would always prefer Agni Chikitsa and Matra Basti during the flaccid stage, considering the patient as a Avartavaka. Later, when the patient develops the spasticity, then only I would prefer Pindaswera and maybe other Brahman Bastis. Either simply it could be Matra Basti or Rajayapan Basti would be preferred. And I have already told that only when the patient has a persistent spasticity and there is no recovery phase, then I would be preferring Virechana as a kickstart to facilitate the recovery. Then Ekangavira has dose which company do you suggest? Company is something different. Dose is usually 180, that 50 milligram, 50 milligrams tablet. 180 or 1 BD is the usual prescription as with the company. With this, I think I will conclude. There are no more questions. So I'll conclude. Thank you. Next, we will take up headache.